This is actually probably the first, should be the first talk. It's called Recognition of Golden Hour in Pediatric Emergencies. Now, when we talk about golden hour, the term golden hour and platinum minutes was actually coined for trauma patients, adult trauma patients, where the minute or the first few minutes or the first hour when a consultant or when a doctor recognizes that the person is sick and the airway, breathing and circulation have to be immediately taken care of. If whatever has to be done is done within the first hour in trauma victims, the outcome was supposedly much better when compared to if it was delayed a bit. So the same concept of golden hour I have, kind of extended on to all pediatric emergencies, all kind of pediatric emergencies, be it seizures, be it a child presenting with respiratory distress and failure, a child with shock, a child with trauma, metabolic emergencies. So all kinds of pediatric emergencies, we need to extend this concept of golden hour. And when can you extend this concept? It is imperative and important that the doctor who's dealing with these kind of children is able to recognize that the child is sick. And so the moment he recognizes that the child is sick, whatever interventions, whatever life-saving interventions can be started. And so the outcomes are definitely better when compared to if the child is not attended to immediately. So this is called the golden hour and platinum minutes in pediatric emergencies. So a little bit of introduction on children. How are children different from adults? So sick children is not equal to sick adults, and treating a child is not equal to treating an adult. It's just not that the body surface area is different. It's just not that the size is different. The illnesses are different, and the physiological and pathophysiological mechanisms that happen in children are way different when compared to adults. Sick children, they deteriorate very rapidly. They do not give us that enough time that the adult may give. So an adult with shock, an adult who's breathing fast, their reserves are much better. Their physiological and pathophysiological mechanisms are much better. So they may tolerate illness and sickness for a longer time. Whereas in children, the deterioration in sick children is quite rapid. So as a doctor, as a pediatrician, the golden hour needs to be recognized and appropriate interventions need to be implemented early. An ideal training which was happening the pre-COVID pandemic was a simulation-based training, which means that, we take a mannequin and we give a case scenario on the mannequin, and we have everything, whatever is needed for resuscitation of the child close by. And we just give a case scenario and presume that the mannequin is a live patient, and a team is built and the team lead takes over from the case scenario and keeps going about how to deal with a sick kid. So this simulation-based learning, it makes learning very easy and interesting. The skills that are learned are retained better and are applied appropriately when the need arises. Unfortunately, at this point, till the pandemic is under better control, we may not be able to do the simulation-based training for a larger group. We still do it in the hospital, in the emergency room. For nurses and doctors, it is repeatedly carried out almost every 2 weeks, every month. There is a case-based simulation going on in hospitals, especially at Manipal Hospital. So what I have tried to kind of simulate something close to a simulation-based training is case and video-based training. So you will be seeing quite a lot of videos in this particular session. Children should never be allowed to become hypoxic or hypotensive, if at all possible, whenever possible. So the concept of, especially, at least children should never be allowed to develop a cardiac arrest. The concept of BLS is beautiful. You go and you start resuscitating a child who has a bradycardia or asystole or respiratory failure. It's a very life-saving concept. It's important. It's extremely important. But what I keep telling my doctors and my junior colleagues is that we need to pick up that child who is sick early before going into a cardiac arrest. Yes, you can resuscitate a child who has developed a cardiac arrest, but as all of us know, out-of-hospital cardiac arrests have a very, very poor outcome. In-hospital cardiac arrest should not be allowed to happen. So the whole concept is that wherever any pediatrician is practicing, please ensure that you pick up certain early warning signs in children early. And if you in your hospital cannot manage that particular scenario, then you may just have to stabilize the child and scoop and run and refer to a tertiary center where appropriate measures can be taken. So, hypoxia and hypotension in children account for more than 95% of cases of bradycardia and arrest, as opposed to adults when they can develop a myocardial infarction with arrhythmias, they can have a dissection, they can have hypertensive emergencies. Whereas in children, it's very rare. Very few patients, less than about 5 to 7% of cases, actually come in with an arrhythmia-related problem or any other kind of a rare problem causing, a cardiac arrest. So hypoxia and persistent hypotension is what accounts for bradycardia and asystole in children. And as pediatricians who are well trained, it is your duty, our duty, to pick up these kids much early and prevent them from going into a bradycardia or an arrest. And as you all know, it is important to resuscitate the heart and restore the brain. So even if the child comes in with a bradycardia or an asystole, it's important that the brain be restored as well. So the heart coming back after half an hour and after that the child going into a severe hypoxic brain injury is not what we want, is not what the parents want. So at least to prevent this, a pediatrician should be able to pick up something called early warning signs and be able to prevent this child from going into a respiratory failure or a bradycardia, cardiac arrest. So for this, the Pediatric Advanced Life Support has been training millions of doctors worldwide on how to approach a sick child. So it's almost the same that I'm going to be using with a little bit of tweaking here and there. So when a child comes in to your clinic or to the hospital emergency room or to the adult emergency room, you feel the child is a little sick. So it's very simple to just go about this protocol or the way to assess. The first is called initial impression. Within 5 seconds, you just look at the appearance of the child and maybe just have one look at the breathing and color. Within 5 to 10 seconds maximum, the doctor should be able to assess if this child is sick, needs immediate resuscitation or needs immediate evaluation, or is the child okay enough to be waiting in the clinic. So that is the initial impression. Then comes the primary assessment, which takes care of the airway, breathing, circulation, disability, and evaluation. Then is the secondary assessment, where we talk about a very focused medical history, but extremely brief medical history, which is coupled with a thorough head-to-toe examination. And finally is the diagnostic test, which we may order for. I will be going in detail into each of these right now.